Good evening. Welcome. So glad to see you. I'm Rebecca Berman, thrilled to moderate tonight's conversation with our host, the esteemed epidemiologist, Glenn Grossman. As many of you know, Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology forecasting and advanced analytics with Bristol Myers Squibb, Sanofi, Novartis, Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs within the United States and abroad. As always, all views expressed today are his own. So Glenn, I recently heard, according to CNN, the US vaccine machine is moving 5 times faster than the global average. Does that sound about right to you? How are things looking here in the US and abroad? Glenn, you are muted.
Yep, that is about right. Where it's here, so let's look at this. All right, so we are looking at the vaccine rate globally. So here's the vaccine rate. This is the number of people who've received at least one dose. And so the United States is at around 35%. Global average, let's look at the global average. There should be a world option, yeah. So the world is currently at 5.5%, and we're at 35%. So even more than I said, closer to 7%, it looks like, 6 or 7. So yeah. So we're doing quite well in the United States. We've really and I've said this before. The decision from the Trump administration to really focus a lot of resources on getting the vaccines out there through Operation Warp Speed was really one of the things that the Trump administration did well. I mean, I've talked before that there were a bunch of other places that were not optimal, and we're still finding out. The CDC is still going back and looking at finding things. But this idea of really investing heavily without constraint in vaccines was exceptionally well done. It was much better than many other countries. And it's the reason that we're so successfully rolling out. After Biden came in, he really boosted it a lot more, purchasing a lot more doses and doing a lot more screening and all sorts of things. But we definitely got a great early start because of the decisions that were made a year ago. All right, let's see. So that was the question there in terms of that. You want to jump back and let's spend like 5 minutes going over to a high level overview, and then we'll jump into some more questions this week. Okay, so where are we in the US? In the US. So you see that we had sort of these 3 major surges, and now we have sort of this quasi-surge kind of thing that we're in. The first surge, these surges aren't really comparable. So the peaks are really hard to compare because we know that the testing rate was very, very low at the beginning of last year. So it's hard to compare because of that. But what we can compare is where we are now to where we were a few months ago. And so we are a lot better than we were, but you can see that we haven't come down. We sort of flattened out. In fact, we're sort of in this weird spot right now where some states are in worse shape than we were a few weeks ago, and some states are in better. So you can see that there's a sort of these 3 or 4 clusters around the country that are not doing very well now. It's primarily due to the UK variant that's causing a lot of this at this point, we think. And not just the UK variant, there's some other variants that are circulating. The UK variant is by far more contagious and severe in terms of the impact that it's having. But so you can see that the Northeast corridor is being hit primarily by that. Not just UK variant, that there's the New York variants, other variants that are spreading here, but UK is very common. You can see up here in Michigan, Minnesota, Illinois, this region over here is not doing amazingly well right now. Florida is getting hit a little bit worse than they should be. And then also here, Colorado hadn't even I wasn't paying attention to Colorado. When you look at a county level, you can see that there are some hotspots. Over here in Michigan, this is all the UK variant that's really driving it. In fact, when you look over, where am I trying to go? Here, you can see when you look at Michigan, Michigan's levels, let me see if I can pop that up. Yeah, Michigan's levels are pretty much at the same level that they were during the height of the third surge. So Michigan, so they're doing very poorly. And so we don't know how bad it's going to get there. This curve needs to be arrested sometime soon. I don't know if they're gonna have to shut down. I know that politically they've been struggling. The governor was just announcing that they wanted to start pulling back, but there's been some politics and stuff, so we'll see how that plays out. But right now, the shape of the curve, it's accelerating very fast. In contrast, when you look at New Jersey, which was also doing poorly, it's hard for me to pull it up. New Jersey is this orange one. You can see that it was starting to go up, but then we started coming down again. So it's unclear how fast New Jersey, what our situation is going to look like. There's another website, an epidemiologist, Caitlin Jetolina, who had this hypothesis that typically when a region sees the UK variant, when it starts to account for 50% or more, say the 50 to 60% range of all the variants in that local region, then you suddenly have this explosion of cases. And so she saw this in the United Kingdom when the UK variant accounted for 50% or 60%, in this case it was 60%, then you suddenly saw the spike really start to go and it required a shutdown there. The same thing as what they saw in Italy when they got to around 60%, it was suddenly you saw this major spike and they needed to shut down. The same thing in Israel, even with their early vaccines, they still had this spiking that was going on, and that was largely because the UK variant was spreading. The question is, in the United States, are we seeing the same thing? The CDC recently announced that approximately 50% of all the variants in the US now are the UK variant. And I haven't seen the data, so it's unclear what the distribution across the states looks like. One thing that we do have is this website, not that one. Whoops, this one. And so this one it counts all the UK variant cases that have been identified by state. So I can zoom in a little bit here. And so you can see that there are some hotspots. The problem is that these are total number of cases. These are not percentages. And so, and I believe that these are cumulative. This is total reported, not reported in the last week or the last 2 weeks or something. So it's a little bit hard to interpret this website, but still the states with the highest UK variant are currently almost certainly the same states with high UK variant spreading. It's just unclear what the percentage is in terms of referring back to this piece that I was just talking about with the 60%. Still, it's interesting in that when you look at the states that I was just sharing with you, not all of these states are really spiking in the same way. So, for instance, there's 2 states that are kind of spiking. This is percentage cumulative. Oh, this was a follow-up from last week. I think that we mentioned it, but just to touch on it again, there was the question of what percentage of all the cases are we sequencing? And so it's still quite low in the United States. You can see that it varies tremendously across the states. The highest one is Wyoming, that has around 6.6% are being sequenced. I think the lowest one is around 0.1, like Oklahoma, 0.11%. So these are really in poor shape. When you look at New Jersey, New York, New Jersey is around 1 out of every 200 are genetically sequenced. New York is 1.4%. The issue is, so right now this is cumulative. So we have the same issue here that we don't know at a weekly basis what percentage are being sequenced. The other thing is that I don't know how representative this is, the sequences, just because there's so few labs that are actually doing the genetic sequences. When the numbers are so low, the percentages are so low, there could easily be biases that come in terms of what samples are actually making their way into the lab to be genetically sequenced. And it's not very transparent what that process looks like, so it's not clear how representative that is. So this is, I'll just go through the three main variants of concern that's currently being tracked by the CDC. In addition to these, there's also the California variants, but they don't appear on this map. So we've talked about the UK variant, B117. P1 is Brazil. You see that's also widespread, but not at the same level as the UK variant. The totals you can see are quite a lot less. Interestingly, the Brazil variant, which is B1351, was further ahead a week or two ago than we're seeing. Brazil is sort of caught up. Again, I don't know if this is just the labs are happening to see it or whether there's actually more epidemiologic spread that's going on. But in terms of the number of states impacted, you can see that there's a few more that have the South Africa variant. That's the B1351. All right, let's look. I'll do a quick global scan, and that was over here. All right, so as a whole, some countries are in pretty bad shape. You can see in South America, so this is something that we have to continue paying attention to. Remember, South America, it's when you talk about cold and flu season, you're really talking about mid-fall to like mid-spring, typically, give or take. And that's the opposite of where we are here. We're just about to begin mid-fall in the Southern Hemisphere, essentially. Or early fall in the southern hemisphere, and yet there is there's widespread COVID and widespread SARS-CoV-2 infections in a lot of these. A lot of this is the Brazil variant that's spreading, and it's interesting because, in fact, that was one thing that's going to come that I was about to talk about. So I'll jump into this in a second. Let me just finish this out this chart. You can see that there's a couple countries in the northern hemisphere too that are doing quite poorly now. Turkey, you can see Hungary's not doing great. Poland, Sweden. Sweden's come up a lot previously. They thought, oh, they might reach herd immunity as soon as last summer or something. And it turned out that idea was totally bogus. Now they're doing among the worst in the world, despite the fact that they decided to change gears and follow the regular European guidelines a few months ago. They're still not doing very well right now. Also, Estonia is not doing great. Estonia is doing a little bit better than it was, but still not great. All right, the interesting thing about Chile over here is that when you look at the chart, so I specifically called out these countries. You see Bahrain, Serbia, Hungary, Chile, United States, Israel, and United Kingdom, because those specific countries are the highest vaccinators so far. So these are the ones that have given at least one dose of the vaccine. Israel is at around 61, 62%. Although interestingly, so all of these numbers, the denominator is the entire population, including kids. In some ways, that's kind of silly because these vaccines aren't yet approved for kids under the age of 16. So really, when you look at Israel, for instance, I think approximately 80% of people over the age of 16 have had at least one dose. So it's actually better than it looks. And also they've sort of, if you compare where they are versus where they were, Israel sort of reached this plateau. And a question came up, why have they reached this plateau? Is it because of vaccine hesitancy? Is it because of other reasons? I think that the most likely reason right now, we looked into it, was that they're just not paying their bill. Pfizer's cutting them off until they pay their bill. But the Israel government's sort of in crisis right now. It seems like every couple of, like once every couple of years, they have a crisis with politics. And they're kind of in this political crisis right now where they're having these re-elections and it's not clear who's in charge. And so right now the bill to Pfizer has not yet been paid. And so Pfizer's cutting them off until they get the bill for new vaccines. So right now it's just, I think that's the major issue in Israel. Other countries are still improving. You can see that Chile was starting to do well. They at first, there was a period of time where they were accelerating rapidly. Then it started to slow down a little bit. But interesting, so the top three are Israel, United Kingdom. Here, let me come back to restriction. Israel, UK, and Chile. And interestingly, when you look at this website, over here, you can see that despite Chile's success as being one of the top, did I say? I was saying Israel, United Kingdom, and Chile. So Chile's third at 38%. Despite their success, they are in a surge. They're still going up. In fact, they're among the highest that they've recorded so far. Again, earlier on, the testing level wasn't great. I don't know what the testing level is now, but they're in a surge, which is terrible. United Kingdom, which is doing great now, had that surge earlier on. They actually shut down for a while, and then the vaccination is now helping to keep it down. United States, you can see we're sort of struggling. This is, again, I like to point out, this is a weighted average, that some states are doing really well and are going down. Some states are doing not as well. In fact, let me pause this for a second and show you another slide. This is Divock. Give me 1 second. All right, so when you look at this website, this shows all the states at a glance. So you can see that some are really standing out. Like Michigan here is standing out, as that we just talked about, is going way up. New Jersey's was going up and is now starting to go back down again. I think largely the reason that New Jersey is starting to go down, let me pull that out, is because of the seasonality. We're now exiting typical cold and flu season as we're in mid-April. And so I think that that's really the biggest force. People are spending more time outdoors, and so it's easier to physically distance and that kind of stuff outdoors. All right, but when you look at where the US, just looking just visually, graphically, you can see that there's a lot of states that are doing really well and have come right down. Like a lot of these states down here are doing quite well. There's a handful. I think the last I saw, it was something like 5 or 6 of the states that are up here are accounting for almost 50% of all the cases in the United States at this point, which is very surprising. But I mean, it makes sense when you look at Michigan up here. That state alone is capturing quite a lot of all the cases in the US. But there's just a few states that are doing particularly poorly. When you look at this that I was just showing, you can see that it's the hot spots that are the red ones that are really accounting for much of the cases in the United States. So I wanted to just go back to the vaccines real quickly, and then we'll open back up to questions. That was back over here. So interestingly, I took the major vaccinated countries, and I wanted to just see what they were looking like. Chile, Bahrain. Look at Bahrain, how poorly Bahrain is doing right now. I can't really pull it out. There it is. So Bahrain is in a major surge. They've been really good. They're fifth in line in terms of how well they're doing. So they're at 30% vaccination rate, and they're still in this major surge. So it looks like one of the insights that we've sort of had is that you really need to get a lot of people vaccinated. The first hint that you get of an impact is the death rate starts to go down when you sort of get a 30% vaccination rate. And then you start to see the cases start to come down at approximately 50%, if Israel is our guide, and when we've looked at some other areas. And so that's what we're looking forward to. Again, right now, the United States is not yet quite at 50%. We're at 35%. However, when you look at subpopulations within the US, let me see if I can pull this up real quickly. CDC COVID. Whoops. All right, so I'm looking at cases and deaths, and I'm looking at vaccinations. Where am I? All right, so what we're looking at here is the percentage of the population over age 65 that have been vaccinated. We're at 78.5% have had at least one dose. 62% are fully vaccinated. So we're already, this is the reason why the death rate is not getting higher, even though some of the states' numbers don't look very good. And this is the reason that even as states start to change their policies and open up more, it's probably not the worst thing in the world if their numbers of vaccinated people stay high, which is good. When you look at the population over the age of 18, we're at 46% across the United States. It does vary some by state. I want to look at people, percentage of the population over age 65. You see some states are doing better than others. So for instance, here's South Dakota at almost 87% of the population over age 65. New Jersey, well, let's look at some of the poor ones. So even the ones that are not doing well, Arkansas, Mississippi, Alabama, they still have over 68% of the population of among people over the age of 65, over 68% are vaccinated. So that's still, it's not amazing, but they're still getting in a good direction. All right, with that, let's open it up to questions, because there were some interesting questions, and I'm spending a lot of time on this stuff.
No, this is great. This is really impressive, Glenn, the way that you're able to toggle between so many different sites. Just, to me, I just think of it as being like an orchestra, and you're playing all these different instruments all at once. And we're all very fortunate that you're able to share so much good information with us at just a click of a mouse. So thank you for that.
Thank you.
So yes, lots of very interesting questions. Thank you everybody for sending in these great questions. So let's start off with the question, can different COVID variants break through the vaccine shield at different rates depending on whether someone has had one dose or two?
Yeah, that's a really interesting question. And so previously we had talked about how well the vaccines protect against the different variants. But this is a slightly different question, and we have a good answer now because we have some real world data. So interestingly, Israel that we talked about, that was just so amazing in terms of how well they were able to vaccinate the population. So like I said, around 80% of the highest risk people, or rather 80% of all adults, like let's say, in Israel have been vaccinated. So that's a very high number. So because of this, they have a lot of real world data. And what they found was that among people who got their first dose until so between their first dose until 2 weeks after their second dose, like that window of time, they were more likely to be infected with the UK variant than people who were not vaccinated. And so that's really interesting. This was what's called a case control study. And the case in in this situation was people who were vaccinated with this is the Pfizer vaccine, the BNT162b2. And then the controls were people who were not vaccinated. And so it was a really interesting study, the way that they designed it. So the UK variant, remember, we've talked about this, the UK variant is like 50% or more contagious than the regular other circulating variants that are out there. And so as a result, there was this question about how well the vaccines would prevent against it. People who have only a single shot are still at risk from the UK variant, and the UK variant is was more likely to break through in people who only had one shot. However, among people who had two shots, and so were fully vaccinated with the Pfizer vaccine, they were protected from the UK variant as if there was no difference, which is great news. However, the South Africa variant was able to break through. So among people who were fully vaccinated, so had two shots, and it was 2 weeks after their last second shot, the South Africa variant was able to break through. Luckily, the South Africa variant is not as contagious as the UK variant. So it's not quite as worrisome. However, if the South Africa variant becomes dominant and starts to spread around the world, and in particular around the United States, then that could be something that we'd be a little bit worried about, and we would want to start looking about getting booster shots or something like that when that becomes available. There are clinical trials currently evaluating that in the vaccines, looking at whether booster shots are required in the fall, and if so, looking at when we should start rolling that out. But the clinical trial results haven't come in yet. But so far, so it was just interesting that there are, depending on where you are in terms of getting your vaccine, if you've gotten no vaccine versus the first shot versus the second shot of the mRNA vaccines, you're more or less likely to be infected with different variants. We don't know yet for AstraZeneca or for the Johnson & Johnson vaccine what that looks like. So for instance, the J&J vaccine is only one shot. And so we're assuming that, I think I showed this last week. Let me see if I can find it real quick. So in terms of how effective the different vaccines are at preventing the variants, the J&J vaccine is around 72% effective at preventing UK, even after that first shot. And so this is both at preventing the disease and preventing the infection. In terms of the J&J vaccine preventing the South Africa variant or the Brazil variant, it's a little bit less effective for those. So after that one shot, you'd expect the South Africa and the Brazil variant to be a little bit more effective at breaking through. Still, you still get a fair amount of protection, and you get even more protection against severe disease. But you'd see a little bit more of this versus some of the other variants that are out there, simply because of the preliminary results that we're seeing. All right, I'll leave it at that.
Okay, thank you. Thanks for sharing these interesting details. So let's go back and please pull up the US map, Glenn. We have a question from Deborah about the infection rate in the Northeast versus the South. And Deborah, if you could please unmute.
Hello.
Hello.
So, Glenn, I am very curious about the New York, New Jersey, obviously, because we live in New Jersey. Why is it so bad here, but not anywhere like in the South? And obviously, Florida, we've had our eyes on for a while, but that's an anomaly for now. But the rest of the South, what's your take on that?
Yeah, it's a really good question. I think the biggest answer is the spread of the UK variant. So you see that it's isolated in specific states. We're not seeing it in New York, and it's interesting. New York has more of the New York variant, and so that's also quite contagious. This map isn't really good at showing it actually, but the UK variant is really I think the UK variant is more widespread than is actually being detected in some of the screening that's going on, and so the map I think is failing to show that. That's one thing. The other thing is when you look at cold and flu season, I think that the South has more moderate temperatures that we're not going to see in the Northeast for another few weeks or a month or two. And so as a result, they're already spending more time outdoors and as a result, that's dramatically reduces the risk. And so the typical cold flu season risk factors start to go around. The amount of humidity in the air, that kind of stuff all changes. So I think that there's just a geographic advantage that they have simply just because of cold and flu season, just this time of year. I think that there's some other things. I mean, Texas, it's interesting, for instance, the Texas governor was just talking about reducing even mask wear, like all constraints on Texas in terms of any policy constraints. And yet when you look at policy at Texas, so this map I was just showing you. Texas isn't doing very poorly right now. And so it's not because of the policies, it's not because of these other things. I think largely Texas has this huge advantage of just being geographically located in the right place, and it just makes it easier for them. There's some other issues involved as well, like urban versus rural. If there's higher population density, then that means that it's easier to potentially infect other people around them. If people are more spread out, then maybe it's a little easier to not infect other people. I'm not exactly sure, but I suspect that that's largely what's driving it. But so it's mostly that I think going back to the time of Hippocrates in ancient Greece, that was one of the first insights that he found was its location. That geography has a major impact on health, even more than viruses or a lot of other things. It's just the geography.
Thank you, Glenn.
Sure.
There he goes, citing Hippocrates. Of course, why not? So now that more and more people are getting vaccinated here in the US and of course around the world, there's lots of discussion about vaccine passports. Can you tell us more about these vaccine passports and are any countries requiring them? Are there digital records? Do you anticipate vaccine passports being something that will happen here in the US?
Yeah, so we talked a little bit, just very briefly, a couple weeks ago about vaccine passports in general. And vaccine passports are required for other diseases. Let me see if I can pull it out real fast. Here. So for instance, yellow fever requires a vaccine passport, essentially. It requires proof of vaccination for access for these countries for yellow fever, that people have been vaccinated. And so this idea is not new. The question is political, whether it will be required. I think, frankly, it's the biggest question will be, say, 6 months or a year from now, when variants might be able to break through and vaccination becomes more interesting. I don't know what that's going to look like. However, when you look at the politics of it, there's been a little bit of interesting work. So, for instance, Morning Consult, I've looked at their polls before. I've shared with the folks here. There's a lot of support for giving digital proof that people have been vaccinated. So right now, a lot of us are carrying these cards around if you've been vaccinated. And then there's also a record at the facility if you were vaccinated there. And so the question is whether there should be digital proof so that we can sort of have access to places. A lot of people support it. Some people oppose it. If it's required, then more people oppose it. And it's interesting that as you get more and more specific, should employers be allowed to require it? Then you have more people opposing it. Should we require that anyone who's been vaccinated carry digital proof? Then more people oppose it. Should we allow businesses to require proof of vaccination to enter? So, for instance, airlines have been talking about requiring vaccination. Some universities have talked about requiring vaccination. There's more opposition depending on that. I think that currently we just allow private businesses to make their own determination on this. We have this idea of the free market in the United States, and I think I don't think that there's going to be a political will to challenge that. So, for instance, airlines, there's a business benefit for them if they can demonstrate their safety by requiring vaccines at some point. There's universities by requiring this. One of the things that I've shown earlier, I can come back here real quickly. Let's see if I can find it in 10 seconds or less. I'm looking at this. So basically, I wanted to look at cases by age, demographic trends, age over time. So there's this really interesting table here that's not resolving. Oh, there it is. All right, so when you look at the age groups that are most likely to get the virus, you can see over time, you can see that the ones that have the most, that are really getting it at the highest rate, are the 18 to 24-year-olds, or the dotted green lines. The next is 25 to 34-year-olds, and then the next are 35 to 54-year-olds. But when you look at the very highest, the 18 to 24-year-olds and 25 to 34, these are really people who are spreading it. In fact, over the summer, this dotted line, the 18 to 24, these were predictors of the spread and the surges around the states. So first, you would typically see uptake of cases in this age group, and then they would spread it to the local communities the most. And so it makes sense that universities would want to require vaccination, because otherwise they could spread to the local communities and really cause new surges and new outbreaks. So it makes sense that there's an interest in them doing that. When we look at passports, so I think that that's likely to happen. One interesting thing that we're seeing now is an increase in fake COVID vaccination cards. There's a whole market that's actually started to develop specifically for forgeries on COVID vaccination cards, to the point that the FBI has come out with an announcement saying that it's breaking the law. It's illegal for people to falsify a government ID card like this. And so it's interesting. There could be legal consequences. It's punishable under Title 18. I don't know anything about Title 18, Section 1017, but apparently the FBI is taking this very seriously and is starting to look to crack down on this. So there's a whole market now for these fake IDs for the vaccination. And you would think that who would even think to get a fake ID, particularly when the vaccines are so effective. But apparently, so that's where we are. I don't know in terms of anything more than that. Based on this, it seems like there's a lot of worry about the government requiring vaccine passports in the United States. Other countries have been looking at this. So for instance, Israel has been looking at requiring vaccine passports, other countries for COVID as well. Right now, it's not clear where we're going to end up on that. It's politics.
To be determined. All right, well, this is an interesting chart. Okay, so Mark, if you could please unmute. Mark has an interesting question about hospitalizations and deaths.
Yeah, thanks. Thanks, Rebecca and Glenn. So I don't want to put words in your mouth, Glenn, but I think I know where you're going with this. Like, we're about 3 weeks after this uptick in cases, and you're seeing hospital rates go up, like you said, with a younger crowd. But it seems we're at a place where we would expect a decoupling between hospitalizations and deaths because we're vaccinating the older folks. Would you agree with that?
Oh, absolutely. I was just looking at that the other day. Let me see if I can find that here. So basically, here's cases, and you can see the case curve over here. So this what I want: daily trends, cases, 7-day moving averages. So at the United States, at a high level, you can see this is where we are with cases. When you look at the death chart is continuing to go down. So I think that you're exactly right with the decoupling. When you look at specific states, so for instance, let's look at Michigan or New Jersey. So you can see that the case rate has been going up dramatically. They're at roughly the peak of where they are in the second surge. So this is an interesting case study to see, okay, well, how does the death rate look? Oops, that's not going. The death rate. And you see that we're not anywhere near where we were at the second one. So for instance, let's pick a specific date. So November 12th stands out. You can see November 12th here. We're already increasing dramatically in terms of the number of cases. And deaths by November 12th had a very clear uptick at that point already. It had already been increasing for weeks at that point, consistent with the rate of the other. And yet when you look here where we are in Michigan, you see that we've been going up. We're almost at the peak. So we would have expected a lot more deaths at this point. And yet because the vaccination has been going on, you don't see anything like that. So we're lucky that we're in a great spot. We do see this decoupling. Now, having said that, remember that the death rate and so the one thing is the hospitalization rate. I don't have a good chart here for hospitalization rate in Michigan. The hospitalization rate in Michigan is high right now, and concerningly high. So that is something that we need to worry about a little bit, even though the death rate is not quite as high. The one other thing is long COVID. So people who get infected with the disease, even if they don't have an acute hospitalization or death, many people have sequelae or consequences of the disease that can last for months after. And we don't know what that long-term outlook looks like for a lot of people. And some of it is life-changing in terms of it causes fatigue in maybe 10% of people who get infected. And so those are disconcerting, and it's still a reason that we need to be worried. But the most important issue that we've been talking about over the last year or so is death, followed by hospitalization in terms of our ability to deal with it. And clearly those two first things are hugely reduced at this point. And so right now we're at this weird stage right now, trying to maximize our vaccination rate and reduce this stuff. Did I get mostly to your question, Mark? I'm not sure if there was a follow-up question there.
Yeah, and is it just the variants are harder on the younger folks, and that's why hospitalizations are so stubbornly high?
Oh, that is a really good question, actually. So that's an open question. The UK variant is around 50 to 60% more contagious, and among people who get it, it's around 50% more severe. And we believe that that's the case among everyone who gets it, regardless of age. So it could be the case. Right now, one of the things that they're seeing is that it's younger people who are being hospitalized in Michigan and some of these states. And the question is it because the UK variant is targeting younger people, or is it because it's targeting people at the same rate as they would have, but the people at the older ages are vaccinated, so they're protected? So all we're seeing are the younger people who are actually getting infected because they're not vaccinated. I believe it's this latter case that I'm describing, where I think that it's generally more contagious and more severe for everyone, but we're only seeing the younger people getting the severe cases right now because they have a lower vaccination rate. And so we are seeing that. We are seeing this different age distribution currently in hospitalization around the country.
So then just the benefit of age seems to be offsetting the greater severity of the illness on that younger population. Does that seem to be the case?
Yeah, so death for sure. Hospitalization is still higher among them, but that's probably likely related. So what I think you're referring to is the infection fatality rate. And I think that, in fact, let me see if I can pull that up specifically here. I think this website will say it better. Oops. This one. This one. IFR. So this is the case fatality rate, not quite the same as the United States fatality rate. So surprisingly, we're not going down here in the United States as much as I would have expected based on this. But it could just be that it's still, there's so much noise right now that some of the states are not doing well. Some states are that we don't really see the case fatality rate going down. But I think that what you're saying is correct. I think that I would expect that the case fatality rate should be going down as a result of that. All right, Rebecca, back to you.
Okay, thank you. Mark, thank you for those great questions. And Glenn, thanks for clarifying all. Terrific. So Glenn, you spoke about the long haulers, and we've spoken about this in the past, and how now in many cases, COVID is now considered a psychiatric illness. Could you touch upon that a little bit more about, I know that you've looked into this week about some of the psychiatric components and the brain issues.
Yeah, in fact, there was a good article that I pulled out here because this had some really great graphs. So this was a large study that was conducted. So 236,000 survivors. This was done in, oh shoot, where was this done? I think it was looking at a large data set. I think this was
Lancet.
in the US. Well, no, it was published in the Lancet, but I think it was a US data set that they were looking at. But anyway, so they were looking specifically at the sequelae. I forget which data set that they were using. I should have pulled that out. But anyway, so the key takeaway here, let me pull up this chart. All right. So basically what they did was they compared people who had COVID-19 to the flu. And then they also compared people with COVID-19 to other respiratory tract infections, just to see if because that would be just a similar, there should be, because flu, you don't typically think of causing psychiatric illness or whatnot. And so it would be a good apples to apples comparison to try to see if there were differences. And what they found, so any number, so this is, the HR is the hazard ratio, any number above 1 means that there was something that was more effective, it had a bigger effect. Whereas if it was under 1, it would be protective. So over 1 is bad. P-value, if it's statistically significant, then that means that it's real. If the p-value is not right, I mean, it's tough because they've looked at so many things that sometimes you sort of have these false positive results. But as a general broad stroke of looking at it, it's fine for this discussion. But so you see that there are some things that were really strongly associated with COVID-19, far more than you would have expected from, say, if someone had gotten the flu or something. So for instance, bleeding in the brain was much more common. That's neurologic rather than psychiatric. Ischemic stroke was much more common among people who had COVID. But interestingly, some things that you might not have considered. So for instance, among people, if you compare COVID-19 to respiratory tract infections, for some reason, Parkinson's disease might be a little bit more common as a side effect. That's something that people are investigating now. Let's see, when you look at, some of these are a little bit less common, so I'm not going to talk about it. Dementia is something that seems like it might be related. It's unclear what's causing what. It might be, so for instance, the case that what if someone gets COVID-19 and because they have COVID-19, then what we sometimes call case ascertainment becomes more likely for dementia because the doctor is looking at them. So maybe they already had early signs of dementia, but no one noticed it. So they weren't diagnosed. But then they got COVID-19 and the doctor said, oh, you probably have dementia. When really it wasn't the COVID-19 that caused the dementia. It was just the COVID-19 helped get the diagnosis of dementia. But either way, right now, this is definitely being something investigated heavily because there's a strong relationship that we're finding between dementia and COVID-19. In addition, we're seeing increases in anxiety disorders and even psychotic disorders. So for instance, there's a doubling twice among people who have COVID-19 versus the flu. They're twice as likely to be diagnosed with a psychotic disorder, which is disconcerting. We don't know exactly why that's the case yet. And also there's an association with insomnia and some other things that you might expect. So there does seem to be strong associations. There's some cool graphs here. So in terms of bleeding in the brain, so it's the other interesting thing that I wanted to point out is the days since the acute infection. So you'll notice that these are things that start to spread out many days after someone was infected. So for instance, within the first month or 2 months, you don't see much separation in terms of some of these diseases. Some of this actually is happening months after in terms of looking at this stuff. So bleeding, ischemic stroke, which is a blood clot in the brain, ischemia, you see that starts to separate early within the first month or two, but actually continues separating in the months after they had the acute infection. So there are these long-term consequences that people are having with the infection. And this is when you compare, in these graphs, we're comparing COVID-19 to any other respiratory tract infection. Other ones that I thought were interesting. So dementia, you see a big breakout, which is interesting. Other mood, anxiety, or psychotic disorders, you see these major separations, which was interesting. I think that this was it that I wanted to talk about here. Anything else? This was not super interesting. Oh, in terms of why it might be happening, the question is whether it's encephalopathy, so the infection in the brain was causing it, or what the pathway is. It's not exactly clear, but one thing that we're finding is that when in cases where you do see this, there's much stronger effect sizes. So it could be that this is the pathway. It's a reasonable hypothesis that's being investigated, but let me see if I can pull it out here. So in encephalitis, you see that it's a major risk factor. And so it could be one of the pathways by which some of these other things are being found. Oh, here, when you look at it with or without encephalopathy, mispronunciation. So you see that the effect sizes get really big in terms of the risk with the disease. Anyway, all right, so yes, there is a strong disease. This is something that a lot of people are tracking now. We've known that there are ACE2 receptors in the brain. There was a worry earlier on about the brain involvement. We knew that stroke risk was higher and whatnot. And so now this is consistent with that. So this is luckily, if there's another reason that you need to get vaccinated, this is another reason to get vaccinated to help to avoid these things.
Yeah, this definitely depicts that as a clear reason. And it's interesting moving beyond SARS-CoV-2 as just a respiratory ailment into now these psychiatric ailments and beyond. Another question that came in is, does blood cholesterol determine COVID severity? Could you please tell us more about that?
Yes, that's an interesting question. So there does seem to be a relationship between blood cholesterol and the severity of the disease. So triglycerides, or rather, this is total cholesterol. Total cholesterol doesn't seem to have a huge effect. Triglycerides do. So people who have higher triglycerides are more likely to have severe disease. And it's a little bit unclear what's going on. So for instance, there could be a relationship between poor diet. So someone who has a poor diet, they're not getting enough exercise, and their lifestyle habits are not great, they might have higher triglyceride levels, and that also might be a risk factor if they're not eating well and they're couch potatoes, not exercising, that might be what's going on. But it's interesting that there does seem to be this kind of interesting relationship. The other things that we're seeing here is the HDL. So this is the good cholesterol. People who have severe disease have less good cholesterol. And so typically having more of the good cholesterol is better for the risk factor. So it's interesting that we're seeing this signal. For LDL, the bad cholesterol, we're not seeing much of a difference, but we are seeing this major difference between triglycerides and HDL. So it's interesting that there does seem to be a relationship. A little bit unclear why or what's driving it, but it's interesting that it's there.
Okay. Thank you for sharing that. Okay, so we are at about the top of the hour together. We are going to wrap up. Mark has a question regarding masks. Mark, if you've unmuted, terrific, thank you.
All right, thanks. Like I'm gonna double dip. It's like the big opponents of wearing masks will cite a lack of peer-reviewed studies to show the efficacy of masks. Has there been anything out now that we've had a little bit more time to show the efficacy of masks?
Yeah, there's a lot now, actually. So it has been demonstrated to be effective. Let me see if I can find the slides that support that, though. Give me 1 second.
So Mark, while Glenn looks for the slide, we're going to play magical slides. I feel like I should bring some music along to these conversations. As you know, Mark, it seems like you've been a loyal member of the audience for quite some time. Glenn has over 1,000 slides prepared. So Glenn, are you looking for this slide?
Yeah, so I'm looking there's a bunch of slides that have supporting evidence. Although this is not RCT, a randomized controlled trial. There's some examples. There was a couple peer reviews. I can bring it up for next week. But basically, if you look at in this case, we're looking at a policy of association of state-issued mask mandates with the cases. And so if you see when the mask mandate was put in, this is the reference period, you see that there's dramatic declines in some of these places. So days relative to implementation. This is from the CDC's Morbidity and Mortality Weekly, which is such a morbid title for a magazine. We've talked about this sometime before, but it's a weekly report that they put out. And so it's a very clear association that they've demonstrated in terms of the mandate being put in and the growth rate of the death and the cases. So it's good. Let me see if there's a couple more I can just go to. There have definitely been some good studies. All right. Let me pick this up next week, just because it could take me a while to screen through. I should put all the sum of evidence together in one place, but there's not any in the epidemiology community. There's not really any controversy about this at this point. There's a lot of evidence to support it, to the point that it would be unethical to do any further randomized controlled trials on masks for COVID, just because the sum of evidence is so compelling at this point. All right, that'll be on my to-do list for next week.
Excellent. Thank you for that question, Mark. Great. Okay. Terrific. Glenn, was there anything, should we leave it there for today? Or was there
was one or two things. Let me just pull out, I think that was all the major questions, but let me just pull out, some people were asking about, oh yes, there's something I did want to share. So this was vaccine hesitancy. So I wanted to just spend a few minutes talking about this. People have been asking a lot of questions about vaccine hesitancy, so I thought I would dig into this a little bit. So when you look at vaccine hesitancy, where is it happening? Are there subpopulations that we need to worry about? How can we change the messaging? So there are two things there. One, with the vaccine hesitancy, you can see that there's a lot of change by age. So when you look at people who are hungry for the vaccine, either they already got it or they want it ASAP, you can see that or as soon as they're eligible. So you can see that people over the age of 65 and Democrats tend to be very motivated to get this. Let me make this a little bit bigger. And some of the smallest ones are people 18 to 29 or Republicans. Now, as we just talked about, the UK variant is a lot more severe than it was, than the other variants. So a lot of people 18 to 29 years old thought previously, oh, there's nothing to worry about with COVID, we shouldn't worry so much. But now that the UK variant is becoming the dominant variant, people 18 to 29 years old should be a little bit more worried and should be thinking about getting the vaccine, because it is a more severe disease. It's still not as severe a disease among that age group as it is among older age groups. But at the same time, the vaccine has been proven, it's been demonstrated to be so safe and so effective. There's no excuse not to. The biggest issue for 18 and 29-year-olds is that they don't infect other people and get people who are at higher risk sick or cause them to have severe illness or death. And so that's really the biggest reason why we need to get the 18 to 29-year-olds vaccinated. When you look, so there's a lot of really interesting information here. So when you look at, there's basically a spectrum that we're talking about. Some people are already vaccinated. Some people want to get the vaccine as soon as they're eligible. Some are waiting and seeing. Some are only going to do it if they're required. And some will definitely not get the vaccine. Interestingly, let me see if there's a few over here that I saw that were interesting. So when you look at change over time, let me look at change over time total. What we're looking at here is that the total number who want to get the vaccine as quickly as possible is actually growing over time, which is great. And they're mostly coming from the wait and see folks. So there were a lot of people that were saying, oh, I don't know if I want to get it, I'm going to wait and see. You can see that the wait and see is going down, 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 which is good. Interestingly, we're also starting to pull from some of the definitely not people, or rather, I think it's the only required. Right now, it's a little hard to see. Let me go into the Democrats or Republicans. So right now, you can see that 80% almost of Democrats have either already gotten it or want it as soon as possible. And they're mostly pulling from the wait and see folks. So the wait and see was a lot higher back in December, and they're becoming more and more convinced. Yep, it's that they're motivated. Interestingly, the only if required, so the only if required has dropped a little bit. The definitely not is still 2 to 5%. That could just be noise in terms of what we're looking at. Republicans, so they too are increasing in terms of the number of people that are willing to get it. It's still not high enough, but they're mostly pulling from the wait and see folks. So there's a lot of people who are still willing to wait and see. Hopefully they'll do less waiting over time. Unfortunately, the definitely not folks are still quite high, but interestingly, the only if required folks are that's budging a little. It went down from 10% to 6%. That could still be a little bit of noise, but I think that it could be a little bit getting a little bit better there. When you add up the 46% and the 20%, then you're at what, like 66%, so 65%. It's so I mean, it's still not great, but there's room for improvement among Republicans there. When you look at it by race, so this is among Blacks. We had been concerned earlier on that there was more vaccine hesitancy, but that seems to be disappearing over time because a lot of Blacks are now, they were waiting and seeing, and now they're becoming a lot more confident. And so that the trend is very consistent. It's getting better. Hispanics, I think it's the same thing. The wait and see folks are mostly happy, and they're now wanting to get vaccinated. Among whites, so we're seeing that, unfortunately, we're sort of seeing this plateau. And so specifically in the evangelical community, which tends to be a lot of white people, there's a lot of vaccine hesitancy there. And so somehow we're gonna have to figure out how to address that population. There were a couple of things that I thought were interesting here. Those were the two main ones. Oh, doctors and nurses. This was interesting. Let me see if there's a better, so over here. So no, I thought there was one over time. Give me 1 second. It was asking the question among doctors and nurses if they would get it. So I think that was the only one was the what we're just looking at up here. So, oh no, this was who you would ask. No, it's not on here. We can discuss it next time. Oh, here it is, where they work. So, okay, so the question was, you would think that physicians would be the most likely to want to get it because they're the most educated. And yet, right now, what you see is that there's a lot, they mix the doctors and nurses together. And what I found is that nurses tend to still be a little bit more hesitant. They're not quite as educated as doctors tend to be. And so when you look at this, doctors and nurses as a group, you still have, what is this, like 20% hesitancy, where they either haven't decided yet or they do not plan to get vaccinated. 12% is an enormous number in this population. And so I'm not sure exactly what's going on there, but I think I've seen some other numbers looking at the numbers over time, and these I think are also going down over time, but it's a little bit weird. I don't know what's driving that. Among people who work in hospitals, it's also similar, where you have a lot of people who are vaccinated. I think when you break it out in terms of people do it like within hospitals, when you break it out, you can see that there's wide variation in the type of people in terms of how they're answering. So for instance, people who are doing administrative duties have a lot more vaccine hesitancy because they are trained to do administrative duties. They're not trained to be experts in medical treatment or vaccination or that kind of stuff. So we still have a lot of work to do. If this population that you would expect, so people who do administrative administrative duties, where they're surrounded every day with other people who are on the front line, you would think that they would be more aware. And yet even a lot of these people have hesitancy. So we need to work on this population some more. Next week, we can talk about some of the reasons that people are giving for not getting vaccinated. There's been some interesting studies looking at that. Some of them are reasonable. So for instance, if someone has a pre-existing condition, say they're have if they're immune compromised, or there's some other reason that they can't get vaccinated, then there are some reasons for them not to. Some people are the reason that they're giving is they want to wait to get vaccinated. Maybe they're a 20-year-old, they see themselves as low risk, and so they want other people who are at higher risk to get vaccinated first, even though they might be eligible currently because they work in a hospital. They might say, no, we want the high risk people to get vaccinated first. So there are reasons that are not due specifically to worry about the vaccine. Instead, there are legitimate reasons for delaying the vaccination. But for now, there's still a lot of communication work that needs to be done in the United States.
What percentage do we need for this vaccine to really fully be effective?
Yeah, so that's an interesting question. It comes back to this idea of herd immunity that we've talked about previously. One thing that we've talked about here, let me come back here to the death rate, or let's say confirmed cases in terms of, it won't load. There it is that the numbers that you see in Israel, that when we started getting up to these high numbers, it really brought the numbers down in Israel. United Kingdom also started having a big impact. What we're thinking of, I think, is that you need around 50% of the population to get the vaccine in order to bring the cases down. And you need around, in terms of the impact on deaths, then you're really looking at the high risk people have to have a higher number. So maybe closer to 80%. I think that in deaths in the United States, because we're already approaching that number, depending on the state, we're already going to start to see that impact as the death rate continues to go down. With cases, we need to increase the number of vaccinations to really start to hit the case rate and get that more. When you look at, so here's again, here's the vaccination rate. Where am I? Here it is for one dose. So these are countries that have had at least one dose. You can see that a lot of countries haven't really hit that high number yet. And so the 35% number, now we should see, based on what I've just said, Chile is going up. Their death rate should not be going up if what I've said is true. So let's take a look, real-time test. So Chile, even though the case rate was going up, the death rate is still high, but it's not going up at the same rate that we were seeing as the death rate, or as the case rate going up. So Chile is having this clear spike in cases. The death rate has been high, but not as high as you might have expected, and that's almost certainly because of the vaccinations that have been going on. So you do see an impact in the death rate and hospitalization long before you see an impact on the spread of the virus and the case rate.
All right. Well, we'll leave it there and hope for more good news next week. Thank you, everybody, for being with us tonight. And thank you for the great questions that you've submitted prior to our conversation and during our conversation. Please keep the questions coming. As you can see, Glenn does a lot of great work preparing for the conversation each week. Yes, thank you. And please, everybody, stay safe. Have a great week. Get your vaccine if you're eligible for your vaccine, as Glenn is saying. And we look forward to seeing you same time, same place next week. Be well. Take care.
Thanks, Rebecca. Thanks, everyone. Have a great week. Bye-bye.